Good evening, everybody. Welcome to this month's journal club. We had actually chosen another topic, but ultimately, I think the students decided that this is a better topic. So it shows the democracy amongst us, that we allow the students to decide which topic is helpful and relevant to them. And I think this topic is also pretty good because it is a topic. It is a good common problem that all surgeons deal with, and I think it is very interesting that there are lots of learning points in the conduct of the study, in the inferences and the results drawn from the study, and also comparison with other studies as well. So I think hopefully I think students will learn a lot from this. And Vinod, please share, start your presentation.
Yes. Good evening, sir. Today's topic for the Journal Club is on a modified ligation procedure for prolapsed hemorrhoids versus stapler hemorrhoidectomy for the management of symptomatic hemorrhoids. This study was done by Hibo Ang et al., which is a randomized clinical trial, which was conducted from 2018 to September of 2022, accepted on April 11th of 2022. It is published in British Journal of Surgery with an impact factor of 6.9. Hemorrhoids is the most common benign anorectal disorder, which generally patient with comes with the clinical complaints of prolapse of anal mass and anal swellings, and rectal bleeding, rectal emptying, and defecation difficulties, and anal obstruction. Generally, the treatment for the prolapsed hemorrhoids is excision of the redundant rectal mucosa and suspension of anal cushions.
Vinod,
it is very
Vinod, sorry, it is pronounced anal.
Yeah,
not anal. Okay, pronounced anal. Don't mind my correcting these little things, but when you're in an international forum, it's good to have correct pronunciations. Okay, so anal presentation. Another small, perhaps unimportant correction. This is from BJS Open, which is different from BJS. And surprisingly, BJS Open had an impact factor of 11 when I saw it in 2022. Okay.
I have seen for BJS only, sir. Sorry.
Yeah. You probably saw BJS. Yes, but this is BJS Open, which seems to have a higher, it surprised me, but seems to have a higher impact factor than BJS. Okay. All right. Please go ahead. Yeah.
Yes. And this it's very difficult to resect the redundant rectal mucosa when it is above the rectal cavity around 4.5 centimeters from the anal margin. Anal margin. Yes, sir. And stapler hemorrhoidectomy is one of the device technique in which we use a circular staplering device, which is based on the sliding anal lining theory.
You seem to have a problem with it. Is not stapler, it's stapler.
Stapler.
Everything is. Why are you pronouncing it wrong?
Yeah.
Stapler, anal.
Anal, stapler. Yeah. Go ahead.
Yes. This stapler hemorrhoidectomy has a higher recurrence rate, and patients return to the normal activity very quickly. And annular anastomosis might result in the annular scaling and stapler nail residue, which leads to anastomotic stenosis and anal swelling. Alternative treatment is for this to prevent this anal stenosis is novel stapler hemorrhoidectomy, in which the normal mucosa is left behind, and the remaining, which is the redundant rectal mucosa, will be removed so that the stenosis will be prevented. And another technique in which we use automatic hemorrhoid ligation devices, in which we perform rubber banding or elastic thread ligation at the base of the hemorrhoid. And the common complications are bleeding, pain, and vasovagal symptoms, band slippage, and longitudinal ulcers. And major complications are bleeding, severe pain, urinary retention, and pelvic sepsis. And our aim is to compare the safety and cost effectiveness of modified ligation procedure for prolapsed hemorrhoids with the stapler hemorrhoidectomy in the management of symptomatic hemorrhoids. Study is a randomized single-blind and single-center clinical trial, which is conducted in Potau Hospital and Traditional Chinese Medicine, University of Traditional Chinese Medicine from May 2018 to September 2021. This study was a parallel group with a 1:1 allocation ratio. Ethical principles as outlined in Declaration of Helsinki and Ethics Committee of Pudao Hospital affiliated with the Shanghai University of Traditional Chinese Medicine, registered with the Chinese Clinical Trial Registry. Our study contains a total of 133 patients, in which 66 patients were allocated in stapler hemorrhoidectomy and 67 were allocated in MLPPH. Of these 67 patients, 3 were excluded from the study because 2 were not came to the follow-up, and 1 is conducted in drug abuse, and 1 the patient do not undergo for the complete procedure. Primary outcome data available of total of 130 patients, 64 in MLPPH and 60 in SH group. We have included. Yes, sir.
Go back now. Yeah, what is this called? Anybody?
Consorts charts.
Consort diagram.
Diagrams.
Why is it important, Vinod?
Single page we can get all the data.
Anybody else? Indraja, why is consort diagram important for any trial, especially randomized control trials?
Sir, in randomized control trial, we have to divide the patient into allocate the patients into 2 groups, sir, and based on the inclusion and exclusion criteria, and will subsequently will analyze the patients like who last follow-up and who are in the study.
It is the essential summary of the entire trial, randomized control trial. It will give you all the information that you need, and also how many patients were lost for follow-up, and it also has to give the explanations to how many, why they were lost for follow-up. So ultimately, it will tell you whether intention to treat principle was followed, whether the patients were allocated properly, and they were all followed up to the protocol. Was the protocol fully followed? So this gives you a bird's eye view of whether the study was done properly. So a consort diagram is essential after every study, especially a randomized control trial.
Sir, here, sir, in this diagram. Sir, in the MLPPH group, they said 3 patients were lost follow-up. But here they mentioned like lost to follow-up 2 patients and discontinued intervention 1 and drug abuse 1, sir. So total 4, no, sir.
It has to be 4, yes.
Yes.
I think I don't know why they have excluded 1 from 3 from analysis. They should have been 4. Maybe they have included the drug abuse fellow. I don't know. It's difficult to tell. They haven't commented on that.
Yes.
I thought this was a limitation because I don't think they've done an intention to treat analysis.
Yes.
So in the analysis, they should not have discontinued anybody. They excluded the 3 where 2 were lost for follow-up and discontinued intervention in 1. They have included the drug abuse in the calculation. Okay, but they should have included in the intention to treat basis. They should have included all 4.
Yes.
But they clearly mentioned about drug abuse. They were excluded, sir. But they didn't mention about discontinued intervention.
It could be one of those. You may be right. Yeah. Okay. It could be one of those that they have excluded. Yeah. They shouldn't have excluded any
of them.
Final calculation. Yeah.
Okay. Go on.
Yes.
A consort diagram is an essential for any RCT. Please learn about it. It's very important. Go and look at the requirements for an RCT, and a consort diagram is a must for an RCT. It makes sure that you have a complete accountability of all the patients, all the inclusions, exclusions, and the analysis the way it was done. So it ensures the reader that everything was done properly. Okay, that is the value of a consort diagram. Yeah.
Yes. Can I continue?
Go on.
Yeah.
And the study included the patients of age 18 to 80 years and 2nd to 4th degree hemorrhoids with symptoms and voluntarily agreed to participate in the study with a written consent. And excluded the patient who have acute hemorrhoidal edema and infection or bleeding, diarrhea and fistulas and perineal sepsis and colorectal malignancies and rectal prolapse and anemia, malnutrition and blood coagulation dysfunction and pregnant or menstruating women and not willing to give consent. And a randomization was done by stratified by hemorrhoidal grade, and participants were randomly assigned to undergo either MLPPH or SH. And randomization assignment was produced by a statistician with a computerized randomized number generator, and blinding was achieved with opaque sealed envelopes containing allocations. These envelopes were sent to each physician and opened by the studying staff in a sequence. To avoid the response bias, the research staff with whom the participant had no previous contact will be asking the final questionnaire and giving the assessment of the final efficacy. And the study was open label with no blinding of participants or clinicians or research staff. Preoperative data, which contains age, sex, and previous treatments and the information which we have collected. And before surgery, the colon was prepared with oral polyethylene glycol, and there was no preoperative antibiotic prophylaxis or mechanical colon preparations. And we have in this study, they have involved 8 surgeons. Each operation was done by 2 surgeons. In the procedure for MLPPH, which was done under spinal anesthesia, prophylactically they have given IV antibiotics, in which we have performed with a device that which applies a rubber band and a silk loop to each ligation via proctoscope. And this proctoscope was placed at the lower area around 3 to 4 centimeters away from the anal margin. And this redundant rectal mucosa will be isolated with the device, and the rubber band and silk loop were released onto the lesion, and followed by this silk loop will be further tightened up, which we call as a double ligation. And the above procedure was completed at 3-4 sites, and the proctoscope was removed, and the similar procedure was done 1.5 to 2 centimeters from the anal margin. And the locations and number of ligations will be different based on the patient's hemorrhoid number of hemorrhoids. And band ligation constrict the blood supply, causing the ischemia to the cushions and leading to sloughing off later within 1 to 2 weeks. And resultant fibrosis reduces likelihood of forming of further prolapse in the future. And the stapler hemorrhoidectomy, which is done with a PAH 32 stapler, which is a 36 mm circular dilator, which is introduced into the anal canal, and they will insert sutures were inserted at the submucosal layer at least 2 centimeters from the above the dentate line. And this this procedure for prolapse and hemorrhoids introduced into the rectum, and these ends of the purse string will be removed from the sides of a stapler, and this traction was maintained on the purse string suture so that the mucosal tissue will be engaged in the stapler. And these staplers were closed tightly and then filed. And post-operatively, we'll give painkillers for the pain control like paracetamol, tramadol, and ketorolac. And patients were discharged when the patient is stable. And the questionnaire for the will be asked to the patient through telephone or WeChat, or when the patient comes to the offline visit, when patient comes to the OPD in 1 month. Primary outcomes were was 6 months cure rate following a surgery, and the secondary were cost effectivity, post-operative pain, complications, and quality of life. Hemorrhoid severity score, which contains total of 15, of which contains 4 things like a degree of hemorrhoidal prolapse, number of hemorrhoidal columns involved, and relation to dentate line and bleeding. And these questions were asked at 1st and 3rd and 6 months after surgery. And health-related quality of life score was determined at with EQ 5D 311 score, which has a score of maximum 1, which indicates the best health score. and this was asked at 1, 7, and 21 days, and 3 and 6 months after the surgery. Wexner internal score, which is for the incontinence, which will be asked, contains 5 questions, which contain whether the contains a solid, liquid, gas, or is using pads, or there is an alteration in the lifestyle. And this total of contains from 0 to 20, with greater value indicating the more severe incontinence. And the questions regarding this vaginal incontinence were asked at the 1st month and 3rd month and 6 months after surgery. And pain was determined using a visual analog scale, which contains 0 to 10. 0 is minimum and 10 is maximum. And these questions were asked at day 1, 3, and 7 and 14 days. And cost-effective analysis is used as a main method of economic evaluation, in which we express it as an incremental cost-effective ratio. Incremental cost-effective ratio indicates the increase in the cost for each additional unit of effectiveness was adopted and used in making decision-making index. Can I continue, sir?
Where you should have stopped there, no? First, okay, now you finished the statistical thing, and
Yes.
where is the first point of stoppage? Okay,
Continue, sir.
continue.
Equivalence trial has taken, which is we take it is effective when the difference equal or less than that equivalence trial. Otherwise, we conclude it as an unimportant thing. And if type 1 error was specified at 5%, like alpha is less than 0.05 in a bilateral approximation with a power of 90%. To demonstrate equivalence with 1 minus alpha into 100% confidence, we produce 1 minus alpha into 100% confidence interval, and sample size of 60 group was calculated using this equivalence trial, which is 0.23.
Vinod,
Sir,
did you really understand all this, or did you just copy pasted from the paper? Go to the previous slide.
yes, sir.
About this type 1 and type 2 error and equivalence and all that. Did you understand it, or just copy pasted from here?
Yes, sir. Type 1 error means if the new technique, like now they are comparing MLPH with SH. If even MLPH was not superior, but they are taking it as superior, and we are taking it as a good technique, and we are following, sir, which we call as a type 1 error.
Okay. What is this equivalence with 1 minus alpha and 100% confidence? Anybody knows about it?
What is equivalence?
See, if you do not know, you
Yes,
should not put it on the slide. That's one thing I have always said.
yes, sir.
Okay, so please, in future, I can give you the answer, but I won't. I want you to read up about it and put it in the group. Or if anybody in the group knows, you can say, and I'll tell you whether it's correct or not.
Nikita, can you tell us what is equivalence trial?
No, sir.
Yeah, please read up about it. But from next time, any of you, do
Yes,
not put something on the slide that you do not know. The idea of all these exercises is not to copy paste it from a document. You must understand every single thing that you put on your slide. If you do not understand, don't put it on the slide. Okay.
Yes, sir.
Same principle in the exam. Don't say something that you do not understand. Everything that you say you must understand, you must say with confidence. But for now, what is this concept of 1 minus alpha? What is the concept of equivalence and confidence interval? Okay, please put that, read up about it. It's available on the net. Just read up about it and put 3, 4 lines about it in the group. All of you must do it. Okay.
Sir, equivalence trials means generally when we are comparing two, if it is less than that, what is the value of that equivalence? We say that there is no difference between the two. But if it is greater than that value of delta,
yeah,
then I mean equivalence, then we say that one is superior to others.
Agreed. Correct.
Yes.
What is
Yeah.
this confidence interval then?
That is the study which is true. So like 1 minus alpha is called as a generally confidence interval, which means there is no true procedure was true 95 greater than 95%. We call it as that is confidence interval.
You're generally there, but not completely there. Please read up about it.
Yes, sir.
You're generally there. I agree that you're generally there, but please read up about it and be very clear in your thought process. Okay.
Yes,
And put it
yes.
put it up in the group. Yeah.
See, the equivalence trial, you said it correctly, but the most important thing is there should be a pre-specified meaningful value that has to be done before. You
Yes,
can't do it after the study has been completed. You should say that the value should be 2 or 1 or 2 or 3 standard deviations from the normal. So
Yes,
you
sir.
should set it up before, so that if the values exceed that, then you say this one group or one intervention is better than the other.
Yes.
Otherwise, so this is also called non-inferiority trial as well.
Yes.
Okay, go on.
Okay, continue.
And Kolmogorov-Smirnov test was used to test for normality, and categorical variables present as numbers with percentages were analyzed using the chi-square test or Fisher's test, and continuous data is presented as mean and standard deviation. And intergroup comparisons were carried out with t-test when the data approximates as normal distribution.
What is this Smirnov test?
Sir,
Go
actually,
back one slide.
Yeah. Did you read up about Kolmogorov-Smirnov test?
Yes, sir. When we actually we'll compare with the graphs which are actually present before, sir, so that to know whether it is towards opposite or positive or negative, to compare with an old graphs.
No, that's not correct.
No.
You're looking at the data that you have from your study.
Yes, sir.
And determining whether it is normally distributed or not. What is normal distribution?
With
it takes a bell curve.
Yes, sir.
All right.
Yes, sir.
Okay, so it is normally distributed on either side of a mean.
Mean.
What is the opposite of normal distribution?
Skewed distribution.
Skewed distribution.
Yes, skewed distribution. Why is it important to know whether it is normally distributed or whether it is a skewed distribution? Nikita, let us trouble somebody else. Yeah.
Yes, sir.
Why is it important to know whether it is normally distributed or skewed distribution?
I'm not sure, sir.
All right. Anybody else? Indraja?
Pavan?
Sanya?
Anybody?
Keep going up the ladder. WHO step ladder. Sanya, you have any idea?
If the distribution is skewed, then whatever intervention is used might differ. Is it?
No, the statistical test that you apply
will change
for normal distribution is different from the one that is applied for a skewed distribution. So there are two things. One is on this slide itself. You use the chi-square test for categorical variables.
Like percentages, and which we cannot compare.
Yeah, continuous variables, you use the t-test.
Yes,
but even in that, okay, if it is a normal distribution, you use these tests. If it is a skewed distribution, you use something else. And so to determine what tests you use, you must first know whether your data is normally distributed or not. That's why they have applied a specific test to make sure it is a normally distributed data.
So this Kolmogorov, Smirnov are both Russian mathematicians. It is a non-parametric test which is looking at equality of dimensional probabilities distribution, which is how close it is to a normal distribution. So if the graph comes as, the distance between the two graphs is minimal and it is equidistant, then you can say it is a normal distribution. If it is very wide, the difference between the two tests is very wide, or if the distribution does not, run parallel to the normal distribution, then it is not a normal distribution. So you will have to apply different statistics. So this is what is, in essence, the Kolmogorov-Smirnov test. So basically, you are looking at how close to a normal distribution this particular, study is. Essentially.
Okay, go on.
Yes.
And basically, if the data is normal distribution, you use what is called as parametric test. If the data distribution is skewed, then you use non-parametric tests. So that you have that these things you should know. These are very simple, sort of basic points of statistics. Okay, continue.
The man Whitney U test was used for intergroup comparisons, where alpha value is 0.1 for a normality test, and alpha 0.05 for other hypothesis tests, and p value of 0.05 was considered statistically significant. Decision tree model was used to evaluate outcomes between outcomes and economics of economics of the quality of life and hospital costs. Decision tree model consists of two branches. After every intervention, we'll divide it into two further, and we'll progress the model further. One-way sensitive analysis was conducted to evaluate.
Go back one slide.
Yes, sir.
What was cure and improvement?
Sir?
What you said there are two branches under each, under each intervention.
Yes,
representing cure and improvement. You have written here. What is that?
Sir, cure means completely the anal cavity completely will be normal compared with a normal person, and in improvement there will be improvement in a from the.
How did they measure that?
What did they use? What is HSS?
HSS score.
Was it the only thing, or was there something else that they used?
QOL.
There was an interesting thing. That's why I asked this
Quality
question. No, they have a Chinese native medicine group have defined it, and that definition is given in the paper between cure and improvement. All right. If
Yes.
you look at the paper, all of you go back and read the paper, you will see that there's a cure and improvement defined. And as long as you define something, that is acceptable. So it's not a loose statement. There's a definition for each of those statements. That's what I wanted to impress upon you. Okay?
Yes.
Okay, continue.
One-way sensitive analysis was conducted to know the base case results and to address the uncertainty by varying costs of up to 20% in each direction.
Did you read up about this Monte Carlo simulation?
Sir, actually, this will be for.
No, I'm just asking a simple question. Did you read up about it?
Have you read it?
Yes, sir, I have read it, sir.
You have read it. Okay.
Yes, sir.
What else was there that is new in this?
Did you understand what Monte Carlo simulation is?
That's what, sir. They will try with each probability, which is changing the value, the cost of the procedure, and they will try these variable again and again. In this one, they have tried around 1,000 times, and they will do the graphing, and they will decide whether even after the probability is changing, whether the cost is changing or not.
All right, Nikita, did you read about it?
Yes, sir.
What is it? What is your understanding?
I just understood that it predicts the outcomes, sir, of uncertain events.
Correct.
So based on a choice of action, what all the outcomes we can get from a
Okay, it is. That's I think that's all. That's all I understood. Also, to be honest, first time I heard about it, I read up about it.
Yeah.
It is a mathematical model which simulates various conditions for different variables and predicts the outcome of what is potentially uncertain. Okay?
Yeah.
So it's a mathematically predictive model.
So
That's all
actually,
that's
the definition is computational algorithms which are repeated on a random basis on a random sample, and they have used both the gamma distribution and beta distribution. What we should know is that the gamma distribution is dealing with the cost and the beta distribution with the utility. For example, gamma distribution for in this case is if it is a what is called as the exponential distribution. For example, if you keep on increasing the money, will the comfort level and the cure levels increase? So that is the gamma distribution. So they have shown that despite doing this, that the MIPPH, despite spending less money, was better in terms of all the primary and secondary endpoints they were looking at. So that is the purpose of using the gamma distribution. And the utility value which was looked at by the beta distribution, which means that, for example, for the cost that you are spending, how much effectiveness did you get? So the cost effectiveness of the treatment was used doing the beta distribution. I think it is a complex statistical maneuver which we probably cannot understand very much, but this is the simple analysis of what I could gather by looking at the Monte Carlo simulation.
Yeah.
Anything to add, sir?
That's it. I completely agree. I learned about this thing only after I read this paper. I didn't even know about this.
I also didn't.
Yeah.
Even the Smirnov test also.
Smirnov test, that and the tornado analysis that comes later. These are the three things I had not even heard of. Yeah. Go on.
Continue.
Yes.
Right.
All right.
Now let us come to the nitty-gritty. Pavan, are you there?
Yes, sir.
Come on, tell us the critique of the paper so far. What are the positive points and the not so positive points?
Sir, it's a randomized control study, sir, with a single blinded, and it is a recent study, sir, and 2022.
Yeah.
And it's a relevant topic for discussion, sir.
Correct.
And the aim of the study, and they defined that primary outcomes and secondary outcomes, sir, with proper analysis and with good scores and quality of life also they included, sir.
Okay, you mentioned quite a number of them. Indraja, do you want to take over from here?
Sir, they also obtained the ethical clearance, sir.
Correct.
And they mentioned clearly everything like primary and secondary endpoints. They used all the scoring systems, sir, to compare pain and incontinence.
Correct.
And the one thing, sir, like against like a small number of patients, sir, like around 130 patients.
That we will come to that in the results, because it is not yet. They have not yet said completely. They have gone about the thing. So that will come in the results. We are now talking about the methodology, and initial introduction and things like statistics and everything. Nikita, you want to add? Yeah. Tell me, Indraja.
Sir, one thing I had a doubt, like they mentioned as bubble preparation was given.
Correct. I think there was some doubt about that. Yeah, because they have used polyethylene glycol, but then they have said we have not prepared the colon. So maybe they have given a smaller dose, which they haven't actually.
No. They refer to the absence of mechanical preparation, which means they did not give any bowel washout. But they gave a proper bowel preparation orally with the polyethylene glycol. And I really felt that was an overkill.
Yeah.
Normally we don't do it, but
we don't do it. Yes.
Yeah, that's an overkill. But that is their protocol. Yeah.
Protocol. Okay. Nikita, do you want to add anything to whatever has been said so far?
Yes, sir. I just had one clarification.
Doubt will go later. Add to the critique.
Yes, sir. Regarding the single blind, sir. They mentioned single blind as well as open label, sir.
I think the blinding refers to the people who are analyzing the data. They don't know which group they are. neither the patient nor the treating surgeon has been blinded, because surgeon obviously cannot be blinded, but the patient could have been blinded, but they haven't done that. But the blinding refers to the analysis part of it, I think.
Correct. I agree with that.
Sir, single blind, and generally, if it is single blind, generally it regards to patient only.
Correct. See, I think they have, I think the terminologies may be, slightly different, but, from China, I think there are lots of things which get lost in translation. So probably this is one of them.
No, the single blinding need not necessarily be for the patient, even though it is usually for the patient.
Yeah.
As Ravi said, in this case, the evaluator, the guy who looked at the grading of the hemorrhoids and ran the HSS, all the QOL and SSS scores, that guy didn't know what the patient had done. That is good enough. That is good enough.
That is good. Yeah, that means that they're,
Yeah.
And obviously, surgeon cannot be blinded in this case. Yes.
But they mentioned this study was open label with no blinding of participants, clinicians, or research staff, sir. That's what I.
No, that, but they clearly mentioned at another point that, the guy who evaluated did not know what was happening.
Did not know.
Okay.
Anybody else has, I think, Sania, anything to add to the critique?
As far as the patients and methods are concerned, Ravi, can we just go back to the inclusion and exclusion criteria, because students must understand why they did it.
Yeah.
If you don't mind, you need to go back a few slides.
It's
worth that exercise. Why would they exclude certain things? Inclusion, of course, is 18 to 80 and all that. That's fine. Yeah. Okay. And I would, Nikita, go through each one of these and say why you would not want, why you think they excluded these cases.
Sir, the points which involve all the rectal regions are like anal and rectal symptoms and problems.
Yeah.
That is because it involves a healing process, sir. Like it affects the healing process and
correct. In general,
it's just the outcome.
Yeah. In general, these are confounding factors which give you similar symptoms as hemorrhoids and can affect the healing process. Okay.
Yes,
yeah. Now, why would they exclude pregnant? Pregnant, I can understand. Menstruating women. Sanya, can you think of a reason?
Pain, sir.
No,
pain is a confounding factor.
No, not pain.
Is the bleeding?
Bleeding.
Yeah, bleeding. Why bleeding?
Confusion.
If it could be confused, the amount of bleeding could be confused, sir.
Confusion is one, but something directly related to the rectal bleed. There is pelvic congestion during menstruation.
Yes,
so any pelvic operation can result in higher bleeding at that time. Okay, that is why they have excluded those. Can you think of diabetes and immunodeficiency? What would be the reasons for that? Simple enough.
That also would be the healing process, sir.
Sepsis. Okay. More than healing, it's a sepsis. Septic rates are higher with that. Right. And all others are things which interfere with healing. So that's something I need you to understand. Yeah, go on. Go to the critique now, please. Yeah. Yeah.
Okay.
Okay. Go on, Vinod. Yeah, good impact factor, recent relevant study. Okay.
Yes.
Yeah.
First thing you have to say is, being a doctor, you have spelled doctor wrong. How can you do this, man?
Yeah, go back.
Go back.
Where are you? Something that was glaring in this. No, it's not a critique. but just the circumstances. Did you guys notice anything unusual in this paper? It has a relevance to our country and our government policy. The whole thing is done in a Chinese native medicine institution.
Yeah.
Okay, we are up in arms against the government for allowing Ayurvedic doctors to do 62 operations. Okay, and in fact, one of the common things that they do is hemorrhoid surgery, hemorrhoid or any perianal disease surgery. We are very much against it, but you see how completely integrated the system in China is. In Shanghai, there is a whole hospital, a whole university dealing with Chinese native medicine, and the same surgeons, 8 surgeons there, do stapler hemorrhoid along with some other modified ligation procedure, whatever they have tested here. That's what really hit me, that it is such a mainstream kind of integration. Okay, right. Numbers are small. What else? Experience in this technique. They are pretty good. No, they said 8 surgeons, all of them are well experienced. How the doctor decided for a particular surgery. Why, man? That is not a deficiency, because
randomized, no?
They're randomized, no? Completely randomized.
So whatever the envelope says, they do that.
Yeah. So
no,
that is.
The doctor who is going to do the surgery, they didn't decide.
No. They have mentioned clearly that all 8 doctors were well versed in all procedures.
Okay.
Experienced doctors, all of them were well versed, and 2 of them did each case.
Yes, sir.
So I don't think the second 2 numbers are small. I probably agree, but please note that they had a formal sample size collection, and it asked for only 60 cases in each, and they have exceeded that. Even though you could have a bigger number, technically that's not bad at all. So was there nothing bad about it then?
Yes.
Nothing bad about it? Okay, let me come up with it before Ravi includes or excludes whatever we say. One of them is this, that they included second degree hemorrhoid also. Okay, normally second degree hemorrhoid doesn't need any surgical procedure.
So with symptoms?
With symptoms, second degree do not need any surgical procedure. So even though they had equal numbers of equal in the sense comparable numbers of second degree hemorrhoids in the 2 groups, to even include them in the study would be perhaps not correct.
But significant numbers are second degree. If you look at the
and then they exposed themselves by doing a subgroup analysis of grade 3 and 4, which means that they gave less importance to grade 2. But they included this in the overall outcomes, and that can cloud your judgment. You understand?
Yes.
You may get very good results from grade 2 with both procedures, but not get good ones in grade 4. And so you include grade 2 in this study, I think, is a limitation. And they have never addressed something which is very common in higher grades, which is thrombosed prolapsed hemorrhoids.
Right.
They excluded all inflammation and thrombosed prolapsed hemorrhoids. In fact, neither of them is likely to work in thrombosed prolapsed hemorrhoids. It may actually need open surgery. Okay? And as I mentioned above before, they gave a bowel preparation, polyethylene glycol, which I believe is an overkill. And very interestingly, they had no control on adjunct therapy. It was left to the surgeon, including things like infrared therapy, red light therapy, they call it. So it can confound the pain factor. You understand? So if they have not mentioned who got the red light therapy and who didn't, and they only took a VAS score, so that has a confounding factor on the pain. And 6-month follow-up is very short. If you want to look at recurrence, you really have to look at least 2 years. And as far as their costs are concerned, they have got into some very complicated. That way they succeeded in confusing me also. Even I didn't understand the finer aspects of all those tests that they have run, to be very honest. But please note that they only calculated the direct costs, which means the instrument involved, the consumables involved. but every single cost calculation must include the OT costs, which I'm not sure if they're included or not. More importantly, return to work and when and how they became productive after surgery. That part of it has to be calculated in all cost analysis. Something that is more expensive at the time of surgery cannot be called so if the patients get back to work early and are more productive. You understand?
Yeah.
So all cost analysis must include productivity, post-op, return to work, and things like that. All right. And the cost of complications. All that has to be included. So direct costs, where I use this instrument, it costs so much. I use this many consumables, it costs so much. Has very limited value in cost analysis. Please remember that. And as I mentioned earlier, I don't think they've done an intention to treat analysis. They've excluded 3 patients from the MPPL group. And so that has some effect on the overall calculations. Maybe not a large one. Maybe not a large one. Okay, these were my comments.
Yeah, I agree with you. The other thing is what actually surprised me is that if you are actually tightening a very tight string at about 1 to 2 centimeters from anal canal,
More pain.
it is bound to give you a lot of pain.
Yes.
And if you have done the staple hemorrhoidectomy properly, you should not have any pain at all. Maybe 1 or 2 out of 10. So I am very surprised at the numbers that they have quoted. I don't know whether we can doubt the validity of what they have done, but if logic says that if you have, I can understand the 4 to 5 centimeter string which is above the dentate line, but if one which is 1 to 1.5 centimeters from the anal bud will cause a lot of pain.
Definitely. Very valid point. I also thought of that. You're right. Yeah.
And the other thing is what I agree with you is that the post hoc analysis which they have done to try and include the grade 2 to add to the value of the grade 3 and grade 4. If they have excluded the hemorrhoids which have edema and coming out and all that, I don't understand how they can call that grade 4 also.
Yeah.
So I think there is some of the doubts about the grading of the hemorrhoids.
But there may be a selection bias. That's what I'm
Yeah.
trying to say.
Yeah.
All right, go on, Vinod.
Go on.
Yes.
Continue.
At 6 months, totally 130 patients complete patients' questionnaires and their answers were taken, and patient follow-up was completed on 15th of October 2021. The preoperative
the groups are well sort of matching, well matched. That's all. You carry on.
Yes. Postoperative complications in which in the perianal hematoma are seen in 6 patients of stapler hemorrhoidectomy, and there is nothing like hematoma in prolapse in surgery of MLPPH, and all other are not significant.
There are significant numbers of complications, but they are equal. That's all you have to say. Go back to that slide. Go back to the slide. See, for example, go back to the thing, the complication. Yes. See this cutaneous bridge hematoma, 21 out of 60 cases. It's nearly more than a third of them. Urinary retention in about third of them. Anal distension in about 40%. So there is a significant about 60% complications, but the two groups are equal. That's all you have to say.
Yes, but p-value not significant. That's right.
That's right.
No, that's right. I'm not saying that there is significant 60% complication rate.
Yes,
they may be all minor complications and they may not have needed any treatment, but still there were complications.
Yes.
So 60% complication rate is high, but the two groups, the complication rates are similar, which is why the p-value is not significant. That's all.
Okay.
Carry on.
Yes. And main EQFT with which health-related quality of life was considered, in which day one and day 2 the health-related quality of life was minimal, less for modified ligation procedure and more for stapler hemorrhoidectomy. And comparison of VAS score, it is only significant in 14 days of surgery, and all other are not significant. and which is almost equal in both SH and MLPPH. As sir said, definitions for cure and improvement.
Yeah, it's here, you see. Yeah, yeah.
Now, I think we'll stop here for a minute. Nikita, can you tell me this, the quality of life? What are the 5 factors which are, why is it called 5D3L? Why is it called 5D and 3L? And what is that?
Sir, it's about 5 is 5 disabled.
Anybody?
It's about 5 dimensions, sir. And
correct, 5 dimensions. Which are the 5 dimensions?
Mobility, self-care, usual activities, pain and anxiety, sir.
Correct. And what is the 3L?
L I'm not sure about, sir. D I have seen, I read it about it, but I can't recollect, sir.
No problem, some problem, and extensive problems. So basically, each of them, all the 5 dimensions are given 3 scores or under 3. That is, there is no problem, some problem, and extensive problem. So you get 1, 2, and 3. So basically, if you have the lowest score, that means your quality of life is very good. If you are very high score, then it means that your quality of life is not good. Carry on, Vinod.
Yes, sir. And comparing with regarding cure, there is high a number of cure in MLPPH, which is with a significance of p-value of 0.003, and there is a difference of around 21%. And cost-effective analysis, this was more. The cost-effective analysis was more with MLPPH compared with SH, and the mean total cost per patient for MLPPH was EUR 1080 compared with EUR of 1657
euros,
for.
It's called euros, not
Euros.
euros.
Euros. The currency they have used is euros in this. Yeah. Okay.
Yes. And the difference in the mean total cost was 577 euros.
How much is a rupee per euro? How many rupees to a euro?
No.
Nice to know, no?
Similar to dollar, man. Almost
Similar to dollar. Okay, 87, 88.
70.
87.
Today it's 70, is it? Check the rates. I thought it was 87 or so. Yeah. Okay, go on.
89, sir, today.
89. Yeah, okay. All right. Go on.
Yes. And number of quality associated life years was higher for the MLPPS than stapler hemorrhoidectomy, and the cost effective ratio was lower for MLPPS than for SH. And the analysis of CEA in patients with grade 3 and grade 4 was shown differently, in which the MLPPH was highly effective compared with the stapler hemorrhoidectomy. Comparison of hemorrhoidal score, severity score at 1 and 3 and 6 months, and it is significant in 6 months, which is almost equal in SH and MLPH. And sub-analysis of hemorrhoidal severity score for grade 3 and grade 4 hemorrhoids, which is also significant only at 6 months. For stapler hemorrhoidectomy, it is 1, and for MLPPH is 0. The mean total cost for MLPPH was 1100 euros, which compared with stapler hemorrhoidectomy, which is 1690 euros. And the difference was around 600 euros, and the number of quality associated life years was higher for MLPPH than SH, and the cost effective ratio was lower for MLPPH than for SH. And this is a scatter diagram in which the cost value for the blue were SH group, and effectiveness is the orange is for MLPPH group, in which the effectiveness is almost same for both the groups, and the cost was high for stapler hemorrhoidectomy group, and it is also more scattered compared with MLPPH. And when the graph shown with the incremental cost effectiveness comparing with SH group and MLPPH group, for the MLPPH, for the stapler hemorrhoidectomy group, when the cost was the cost will be always high with when the effectiveness was high, and which shows the right and upper right quadrant, and the results were even less when even the cost was high, which shows in the left and upper and left quadrant.
Yeah, don't confuse too much here. It's very simple.
Yeah.
You can see in the diagram.
Yes, sir.
Upper left quadrant is incremental cost and less effectiveness. Okay.
Yes, sir.
Yeah, and that is more with your SH group. That's
SH group.
most dots, most circles are in
Yes.
the left upper quadrant. If they were in the right lower
Right up.
quadrant, then it would have been less expensive and
More effective.
more effective. It's as simple as that. Yeah. Yeah. Go on.
CA analysis, cost effective analysis.
Yeah, we have covered this. Go on.
Covered this. Yeah, next.
this
Covered
is
this also.
Yeah, this is the tornado analysis. This is
Analysis.
another word that I learned after I read this paper.
Yeah.
Yes.
Okay, that is an individual assessment or analysis of
For each variable.
each variable. That's all. Okay, yeah, go on.
Okay. Let us, who will start now? Let us start with Sanya. Sanya, what is the critique in the results so far?
Sir, I could not find anything, sir. As far as I understood, everything seemed okay to me.
No, there you guys, I'm basically critiquing is means you have to say what
Good
are the
points
correct
also.
points.
Yeah.
What are the good points? What
Yes,
are the
sir.
statistics used? The results,
Sir.
then the figures, all of these things.
Yes, sir. All of the statistics that was used and the result they've obtained is good.
Abdul, are you there?
Yes, sir.
Yeah, Abdul, tell us what do you think of the
Sir, individual variable analysis was a good point in this. And then they shouldn't have included the second degree in the results, I felt.
okay?
Probably that was the subgroup analysis of third degree and fourth degree was right, but not the second group. And then the statistics used, for the results were the complications, what they have said, were comparable is very, I feel so it is very variable.
How do you mean, Abdul?
I mean that, sir, the complication which they have analyzed in both the groups, especially in this case, it was not reliable, I felt.
No, I think it's fairly well done. In fact, they were very good. Day 1, day 3, day 7, day 21, 3 months and 6 months. Very diligently, they have used scores and scales to measure. Actually, it's very good, and I practically agree with Sanya that there is very little wrong to find in the results and the statistics that they have run. Okay.
In fact, they have over elaborated on the statistics to prove the point, which I think is okay, because as I mentioned, basically they've run this what is called as the Monte Carlo simulations, which I think is a good thing to actually to see how random the data are, or how relevant, or how for example the what shall we say, the cost, not the cost, the cause effect relation, how is it actually shown, and also in terms of looking at the cost and saying that using the gamma, the gamma, what is it called? Again, we have to, the gamma distribution, to show that even with the increasing cost, there has been no improvement of the results, which means at whatever cost levels you look at it, the MIPPH was better compared to the staple hemorrhoidectomy. So I think that they have actually gone out of the way to actually prove that, which is good. I think the application of statistics is good, and I think they have randomized it well, and I think their follow-up is good. They have stated everything, and they have actually followed them very well, I think. Anything to add, Nikita or Indraja or Pavan?
Sir, I just want to bring it to your notice, sir. You just
Yeah.
mentioned the follow-up data was finished collection in October 2021, sir.
Huh.
But according to the plan and everything, they are supposed to follow like post of 6 months, sir.
Huh.
So
When did
the
they finish?
study period
So-
is till September 2021,
Huh.
and follow-up they finished by October 2021. They have mentioned, sir. So slight reliability.
Yeah, maybe the that I didn't see. Good, you picked it up. So unless they've been operating till August and then followed it up on till September and followed it up till October, then obviously some of the patients would not have completed 6-month follow-up.
Yes, sir.
But as we have some of the things which Dr. Lakshman has already mentioned, 6-month follow-up for a hemorrhoidectomy is not sufficient. We needed 2-year follow-up to actually be. We will come up when you have the cross references. We'll come to the other studies which have actually shown the 2-year follow-ups, but this one didn't have that.
Yeah.
Though actually they tried to follow those principles of those 2 studies.
Go on.
Go on, Vinod. Why did you stop sharing?
2 minutes past 10 now. Yeah, go on.
Yeah. Please share. Vinod, are you there?
You must have logged out. I
Hello,
don't
sir.
see-
Am I audible, sir?
You're here. Okay. All right. Go on.
Just a second. Sorry. Is it visible, sir? Now?
Yes.
Even I didn't find anything.
Yeah. That's.
sir.
I think that's a fair assessment. Yeah. Go on.
Hemorrhoids. When hemorrhoids progress to grade 3 and grade 4, surgical treatment is often required. And sliding anal theory was the theory which we used as the highly vascular cushions of submucosal tissue that provides substantial support, but due to human standing posture, leading to the gravity and leading for the formation of hemorrhoids. And irregular bowel habits is likely to associate with higher chances of hemorrhoids and straining, and there is a general increase in the venous pressure in the cushions during defecation. And the mean pain score was higher in SS group during the early postoperative phase. And sir, all I told in the slides itself.
Yeah, you already said that. Yes.
Yes.
Yeah. Skip all this and then yeah.
Conclusion. MLPH was documented as cost-effective approach, although it was a longer procedure, and it is provided lower short-term pain and lower Wexner and hemorrhoid severity scores, and it has achieved a better clinical therapeutic effect than stapler hemorrhoidectomy in the symptomatic hemorrhoid treatment.
So now the first question is, would you change your treatment from stapler hemorrhoidectomy to MLPPH?
Sir, still I am worried about that suturing at 1.5 centimeters, because it is just below the dentate line, which is highly sensitive area.
Right?
Hello, sir.
Go on.
What
Go
else?
on.
What else?
Yes, sir. That is a
See, I think for a common problem, the number of, though they have done the power of the study, but I think you need bigger numbers to actually show that whether this is effective or not.
Yes.
And I think they have only mentioned 5 sort of what shall we say, the shortcomings of the study. What are the 5 shortcomings they have mentioned? Which we have already, some of them which we have already referred to. Short follow-up period, and there isn't any, even though they are, this one, the hemorrhoid severity score, which was done by a chap called Nistrom from Sweden, there is no consensus about which is the most effective hemorrhoidal severity score. Simply because, as sir keeps saying, none of them are validated. See, there are some 3-4 hemorrhoidal severity scores, but none of them have been validated. So, which is why it is very difficult to compare different studies because there isn't a uniform score and the score has not been validated. So that is one of the shortcomings of the study. And small sample size, short follow-up period, and there could be potentially a bias because they have chosen to show that MIPPH is better than the. So as the sir said, some of the the cost analysis has not probably included everything. So they have been able to show that MIPPH is more cost effective than staple hemorrhoidectomy. You can't just take the instrument cost alone. You have to look at the entire thing. Some of the things have not been included. For example, they have said themselves that if any extra procedures and things were needed, those costs were not included. How can you, if you are doing cost analysis, you can't say I will include this and not include that and return to work also. They have not said about that. So I think if a person comes into work 3 days before the other one, he would have earned more than the money that he has saved by going through the other procedure. So I think a lot of these things are the shortcomings of it. Is a well conducted study, no doubt, but there are some of the inherent shortcomings with the study. Lakshman sir.
Yeah, totally agree with what you said. Please note that this is a very good study, in terms of randomization, design and all that. But there are certain methodological deficiencies and certain limitations in terms of number and short follow-up, which will tell me that I'll not jump into changing my policy in doing MPLLH or whatever, MLPPH, not MLPPH. So I would still wait for the data to mature before I switch over from stapler hemorrhoidectomy. Okay, go on.
The literature review, have you included the Hubble trial and the ethos trial?
No, sir.
You should have done that, no? They have themselves quoted it. The Hubble trial and then the ethos trial. They are the very important trials. What are the
Vinod, you must really see a randomized, controlled, it should be, and it's trial. You got the doctor spelling wrong. Here you say trail, not trial. No, it's controlled. All this you must give attention to when you make your slides. Yeah, go on.
Yeah, tell us.
Sir, the review of literature, comparison of stapler hemorrhoidectomy with traditional excision surgery, which says that traditional excisional surgery is clinically effective and less costly compared with the stapler hemorrhoidectomy, which have a study of a population of 777, which is also a randomized.
This is the Hubble study, man. This is the Hubble study. They looked at the stapler hemorrhoidectomy versus the standard open hemorrhoidectomy. This was published in the, I think it was British Journal of Surgery. And I think this is the Hubble study.
I can't remember, was the pain the same in both?
No, sir, the pain was
possibly
better.
Be. Yeah, it must be better.
Staple hemorrhoidectomy is better.
Yeah, obviously.
Only thing is the later, when it comes to 2-year follow-up, the recurrence
higher recurrence rate in stapler
hemorrhoidectomy.
Correct. I remember reading that.
Yeah.
Okay, go on.
Yes, sir. Go on. Another study which is comparing with the same stapler hemorrhoidectomy with open hemorrhoidectomy, which says that stapler hemorrhoidectomy is safe compared with the open hemorrhoidectomy, as it causes less intraoperative bleeding and pain and less hospital stay. But at 2 years of open hemorrhoidectomy has more satisfaction to the patient as compared with the stapler hemorrhoidectomy.
Yes, the quality of life analysis was very good with the Hubble trial. And basically they said the quality of life was much better with open hemorrhoidectomy compared to stapler. That was one of the main reasons for the recommendation that open hemorrhoidectomy should be practiced compared to stapler hemorrhoidectomy.
Yes.
The other trial which is very important is what is called as the ethos trial, which was published in 2016. And I think the Hubble trial is the trial which looked at the ligation as opposed to the arterial exclusion and ligation using ultrasound. And that showed that recurrence rates with both of these rubber band ligation and the arterial ligation was very high, about 30 to 40% at 2 years, which is, I think, again, if you look at these two also, I think the MIPPH will probably have the recurrence which will be very high at the end of 2 years. That is probably what is going to make it not as effective as a stapler hemorrhoidectomy. Stapler hemorrhoidectomy has stood the test of time in terms of its recurrence rates, which are not very high. It is comparatively 9 and 7%. 9% for stapler hemorrhoidectomy, 7% for open hemorrhoidectomy. So which I think is not that bad, but quality of life apparently is much better with open hemorrhoidectomy compared to the stapler hemorrhoidectomy. Your final comment, sir?
Yeah, I think it's a good paper. I think Vinod, you did a reasonably good job. But 2 pieces of advice: do not put anything on the slide which you do not understand. And always, please do a thorough check of your wording and spellings. And lastly, please learn to get your pronunciation right, because a lot of good work that you do will be drowned if your English grammar and pronunciation is not right when you're presenting. Okay, you may be very good at your work, very good in your knowledge, but presentation, you must focus. Everything can be learned, and all of us, none of us, English is a native language, but you just have to spend more time and energy on getting your English grammar and pronunciation right. Okay, yes. That's my advice. Yes. Otherwise, good job, well done. Yeah,
I think any students final comments? Abdul?
Sir, Vinod usually does this presentation in a PowerPoint, which doesn't have those autocorrect features. I've told him to use Google. Google is better, sir. Google Docs.
Yeah.
It'll help them, and it'll in the spellings if there's doubt.
Abdul, PowerPoint also has autocorrect, in the sense it'll at least underline wrong ones. So you just have to, it brings your attention to it, and you can then correct it.
Okay.
So you just have to give attention to it, that's all.
Yeah. I think, Abdul, anything else to add?
No, sir, otherwise the presentation is good.
Yeah, Vinod, I think you have made a good effort. I don't know whether, because I heard Nikita also say anal. Is it an Andhra thing? Is that why? No, I'm not trying to criticize you. It's just, for example, all Tamilians say percentage instead of saying percent. 3%, 5%, and all Tamilians, I've seen that. I think that's a Tamil Nadu thing, I think. Yeah. It is not, it's not a wrong, it's not a criticism. It's just sometimes that is
an
what
observation.
Yeah. What you are used to. Is that what they say? Is it anal rather than anal in Andhra? So please correct it. See, the thing is, as sir said, I will just give you an example. Palani Velu, who is one of the greatest surgeons, definitely one of the greatest in India, probably one of the greatest surgeons in the world, took a long time to gain recognition because of his ability to communicate and present work, because he came from a very rural background and his English was not good. So people didn't take him seriously. Ultimately, his the body and quality of work that he did, got him the recognition. But not everybody will be as good or as fortunate as he was. So I think it is better for you to communicate and convey what you want to do in the correct way. Otherwise, your good quality will get drowned in the small mistakes that you make. So please correct that. I think, and again, put up all the whatever sir has said about the statistics and things which even whatever we have already discussed. You can put up more if you understand and study more. I think otherwise it was a good effort, and congratulations, well done.
Okay, I'll end the meeting. Good night, everybody.
Good night, sir. Thank you.
Good night.